actually able to start pretty close to on time this week, or at least what has been passing for on time. I know we've been kind of scheduled for 4 o'clock, but it looks like 4:30 is going to be the time that we're kind of locking in at, which seems to work fairly well for folks. So, without further ado, let's go ahead and get started. Navigator Nation, welcome to BreatheTV for another week, another cold, snowy day here in Michigan. Finally getting some real substantial snowfall for only maybe the second or third time this season. Been a very unseasonably mild winter. Hope the winter has been treating you, or if anybody happens to be tuning in from the southern hemisphere, hope your summer is fantastic and looking forward to getting some of those temperatures before too long. One thing, since it is winter, I always like to encourage people to make sure that when you're going outside, particularly during these cold snaps, you've got something over your face to help capture some of the exhaled moist air and make it a little bit easier for your lungs to cope with the very cold, dry stuff that you're about to inhale. It does tend to make things a little bit easier, reduces some coughing a little bit, reduces wheezing, all that kind of stuff, and is generally a helpful thing. For those of you who might be new to the program, my name is Mike Hess. I'm a respiratory therapist, have been for going on almost 15 years now. I am also a COPD advocate. I work with the COPD Foundation and the US COPD Coalition. I work with a clinic here in town to help people manage their COPD stuff a little bit better and trying to improve the way we manage COPD in general, the way we diagnose it, the way we treat it, the way we manage it, the way we advocate about it, the way we teach about it, all those kind of fun things, just trying to do my part for the COPD community. We started this with a group on Facebook called COPD Navigator. I have expanded out a little bit into a YouTube channel and started doing these live shows a couple of years ago. We try to do them about every 2 weeks, hitting, first of all, some of the latest and greatest news in the world of COPD, and then follow that up with a lesson plan for the day. This week we're going to be talking about some snake oil therapies, how to recognize them, some of the history I've had with working around them and that sort of thing. And what you can do to protect yourself against them. And then also we have some time at the end for your questions and answers. Whatever is on your mind, whether it has to do with one of today's topics, whether it's something you've been curious about for a while, whatever it is, COPD related. Drop them in the comments, depending on what kind of device or what kind of whether you're watching us on Facebook Live or on YouTube Live. The comments are somewhere either off to the side or down below. Wherever they are, drop them in there. You can also tweet at us at COPD Navigator if you have a question or want to get on board with that. I have not been very diligent at keeping up with those tweets as far as advertising and stuff like that goes. So also, if you have the inclination, make sure that you're sharing these videos with other folks who might be interested, caregivers, clinicians, others living with COPD. Invite them to the program, invite them to our Facebook group. Sooner or later our website will get off the ground, but make sure that we're spreading the word as best we possibly can. So as I said, we like to start off with some of the news of the week, and one of our biggest news stories is in the vein of everything old is new again. There's a new study that came out. I gotta flip my page here. Here we go. A new study that came out. I got it through MedPage today. This was published in the Annals of Internal Medicine, another one of those great peer-reviewed articles here in the U.S. This study comes out of the Mayo Clinic in Minnesota, and was looking at treatments in general. What I'm highlighting here is antibiotics in particular, and that will hopefully become clear as we get into some of this news here. But what the biggest thing was this Mayo group looked at a total of 68 randomized controlled trials of patients with moderate to severe exacerbations. And they looked at how those exacerbations, those flare-ups were treated, how they were managed, to see what could be done about them. And what they found was that antibiotics given for 3 to 14 days were associated with, that treatment was associated with increased resolution of that flare-up, of that exacerbation, to a moderate strength of evidence degree, so pretty good, maybe not definitive, but this seemed to be pretty good evidence. Also, less treatment failure, so that not only did these seem to resolve the situation, but it also prevented it from getting worse. And what was also interesting about these was that the findings were that these antibiotics were helpful regardless of how severe the flare-up was, how severe the exacerbation was, or whether it was being handled as an outpatient or an inpatient. There are a lot of folks out there who are able to talk to their pulmonologist or their primary care provider and say, hey, I would like to have this kind of ready response, rapid response, go pack, whatever you want to call it, of a course of antibiotics in the home so that when you start feeling these flares come on, you can jump right on them and immediately start getting some relief. And this kind of bolsters some of that evidence, because what this is saying is that, of course, you would expect these things to happen, go well in the inpatient world, but also as an outpatient. Another interesting thing was one of the co-authors from Mayo pointed out that antibiotics are often not given to people who are having relatively mild flare-ups, those mild to moderate exacerbations that maybe aren't causing a lot of phlegm production. You're not coughing as much, you're not bringing all that stuff up. Doesn't seem that bad. It's worse than usual, but it's not that bad. It's relatively mild. But this data is telling us that this course of antibiotics might actually be helpful in those cases too, and prevent people from going off into those more severe flares. Now, in other good news, systemic corticosteroids given for anywhere from, oddly enough, 9 to 56 days, which is a lot. That's almost 2 months. That's a really long time to be on oral prednisone or those kind of antibiotics. Also associated with less treatment failure. But the problem with that is, and why I didn't loop it in with steroids and antibiotics, is that steroids have a much higher adverse effect rate. Those bad things that happen, pretty much anybody who's taken prednisone knows that oftentimes bad, weird, unpleasant things can happen on it. Mood swings, trouble sleeping, sleeping too much, all those kind of things. That happens a lot more with these systemic steroids than it does with antibiotics. And interestingly, I know I'm using that word a lot, but this was kind of the more I think about this study, the more I'm intrigued by it. There were no effect or inconclusive effects demonstrated by a lot of other medications that we often give, including aminophylline, magnesium sulfate, non-steroid anti-inflammatory agents, and very interestingly, inhaled corticosteroids and short-acting bronchodilators. These are usually the first things we give for a flare-up, particularly our old friend albuterol. But the data is telling us that, yeah, maybe it's good for some symptom relief, but it doesn't really seem to affect the odds of whether this exacerbation gets cleared up or not. So again, this is kind of an everything old is new again, some of the basic stuff that we know, also reinforcing that while those steroids do have effect, the shorter the better. These long regimens that were used to be tradition, the long tapers and that sort of thing, those were certainly no more effective than the short bursts that seem to be the trend these days, for good reason. Limitations to the study include that a couple of the drug interventions only had 1 or 2 trials, so it's a little bit difficult to judge the strength of that data. But by and large, overall, this was a pretty large, well-designed study, and gives us some really good information about how maybe we should be, this is kind of bucking the trend of recent years, but maybe we should be a little bit more liberal, a little bit more free-flowing with those antibiotics in the setting of COPD exacerbation anyway. Our next news coming up is, again, probably one of those things that is fairly self-evident. We know that COPD is a fairly complex condition. We know it affects a lot of body systems, even outside the lungs. It can have an effect on fatigue. It can have an effect on your nervous system, make you tired, make you sleepy, make you a little bit goofy sometimes. We know that it has an increased risk of affecting diabetes and all that sort of thing. But traditionally, we have often managed it simply by letting the doctor or even the primary care provider of any stripe carry the ball with it. They're the ship captain, they do the thing, and everybody else kind of makes it so. But a new study that was presented in the Journal of the American Osteopathic Association, so go DOs, tells us that you can shorten a hospital stay by up to 67%. It can be 2/3 shorter when provider teams hold these things called integrated care conferences, which are a daily meeting, in their words, for providers to share information all at once. However, and they go on to say, the seemingly obvious concept is rarely implemented, according to these researchers. Now, there may be a little bit of cloudiness here because there are a lot of places, especially for my clinician friends who might be watching right now, there are a lot of places that do multidisciplinary rounds, interdisciplinary rounds, that sort of thing. But what this study is telling us, that while that happens a lot, it usually happens right there at the bedside. Everybody's standing up. Everybody's got a whole bunch of other stuff going on. There's maybe food trays coming by, breakfast, lunch, dinner, whatever. There's a lot of other stuff going on. And it's not a great environment for collaboration, discussion, idea generation, all that sort of thing. A little space and time for the large group to have meaningful discussion and or input. So what this study is proposing is that these interprofessional care conferences actually go to a conference room. And while I know that, again, for my clinician friends out there, it sounds like yet another staff meeting, we're talking about a 30 to 67% reduction in inpatient time. Now, this was a relatively small study. They basically looked at one hospital that did these things and then another hospital in the same system to keep it as apples to apples as possible. One did, one didn't. So it's a relatively small study, but they found that the average length of stay for COPD inpatient at the hospital with these conferences was a touch over 3 days, compared to 5.5 days in the hospital without them. COPD patients who were aged 40 to 69 had a 67% shorter reduction, so the relatively younger cohort saw better benefit from these interprofessional conferences, whereas older folks aged 70 to 99 had a 36% shorter length of stay. So it still worked, but because as we get older we tend to have a lot of other stuff going on, even these optimal interventions may not be as effective as those that are focused on COPD. So basically what this is saying is, please, 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 if you are a clinician, emphasize the importance of having interprofessional, multidisciplinary, whatever the multi-group get-together buzzword of the week is at your facility. Let's start talking. Let's start having real conversations about the people in our care so that we can get them home sooner, because we also know that the hospital is not a great place to be, even when you're sick. So let's start getting people out and about a little bit better. Our third news story is going to be a little bit complicated, so I do want to take a moment and say hello to Phil and Janice checking in from literally around the globe. Phil coming in from the UK, where he's up a little late tonight. My math is right, so I appreciate you taking some time out of your evening and stopping by to chat with us. Jan, hello, how are you doing? I believe Chicagoland area. And then Jenny checks in with a research update on diabetic medication metformin used to treat COPD. So I'm going to have to look into that a little bit. I'm going to do a search in the background while I'm chatting away here, and we'll see what we can do toward the end of the program here. And let's see, sometimes the chat isn't always working so well. So, okay, we've also got Bonnie and Orlin and John and Kathy all checking in from the COPD Navigator Facebook group. Welcome to everybody. Appreciate everybody. These are some fantastic folks who have been advocates for quite some time for us. State captains with the COPD Foundation, and of course, fantastic supporters, friends of Navigator, part of Navigator Nation is another one of our people. Rachel has coined it for us. So appreciate everybody taking some of the time out of your afternoon, evening to check in with us. Now, one thing I do want to chat about a little bit here is one of the things that's kind of on everybody's mind, and nothing going on the YouTube. So one of these things that's been on everybody's mind right now, it's been in the news a lot. We've got a lot of stuff to cover with this. The infamous coronavirus. This has been in the news increasingly for the last couple of months. As if you happen to not pay attention to much news, more power to you these days. But this is a new kind of virus. The general idea of the coronavirus is very similar to the thing that gives you the common cold, the upper respiratory infection. This particular virus is fairly unique in the vein of, remember several years ago we had SARS, severe acute respiratory syndrome. Not quite as long ago we had a thing called MERS, Middle East respiratory syndrome. The World Health Organization has tried to get away from these regional monikers, if you will, kind of going back to Spanish flu when everybody kind of hated Spanish people for a while because they associate with the flu. So they're trying to get away from that and go into some of a more generic naming strategy. Now, there's a lot that's been going on, and there's a lot of, frankly, panic going on, and that kind of ties in with some of the snake oil stuff we're going to be talking about later today. So, did a brief update a couple weeks ago. I just want to kind of circle back around to that. I even saw the COPD Foundation, if I can find that real quick, on, no, I don't want to install it right now. Okay, so the COPD Foundation actually even just issued some guidance this afternoon that I saw just before I started the show here. So obviously it's on a lot of people's minds. What they're saying is, we understand the COPD community may have questions about the coronavirus now called COVID-19 because this is a unique or novel coronavirus that came out originally in 2019 toward the end of the year. We want to reinforce that the most important thing people with COPD can do is prevent the spread of respiratory infections with a few simple practices. If you have specific concerns about travel or your individual health circumstances, we encourage you to contact your healthcare professional team directly. So you can get onto their Facebook page. It's a little glowy maybe for the screen, but and they have a list of just a half dozen things you can do to kind of cover some of that stuff. And I wholeheartedly support that. You know, I was looking at, there's a lot that's going on right now, working in healthcare, especially respiratory healthcare right now. We've been getting notices that, you know, all these emergency systems are being activated and all this is happening. And the biggest thing to remember about this is it's a little, and then so we've got that kind of panic on one hand. And then we've got the other side, and I don't want to necessarily name any names, but we've got certain radio hosts out there saying, hey folks, this is basically just a common cold. This is not a big deal. The truth, as usual, is kind of somewhere in between. It is not, in my view, and again, this is going to depend heavily on your individual circumstance, as panic-inducing as a lot of people are putting out there. I've got people who really ought to know better saying this is a bioweapon attack, this is a lot of just basically panic-inducing stuff, a lot of misinformation, disinformation, a lot of that going on. But it's also not something that should just be completely blown off, particularly in most of the people that I'm probably talking to right now, those folks who already have an ongoing respiratory condition, who might have a little bit of a weakened immune system, and that sort of thing. So in preparation for today's program, I did a little bit of looking, and I found some information right from the World Health Organization. And they just actually sent a team to China to the kind of ground zero of this outbreak. And they found that in that area, the epidemic peaked and plateaued between the 23rd of January and the 2nd of February and has been declining steadily ever since. So they're not seeing as many new cases at the epicenter. It's starting to trend downhill. And so since this is kind of where that started, it's reasonable, although not guaranteed, to suspect that some of this stuff will also begin declining around the world. And that seems to be borne out by some of the latest, this is a data report that, and again, this is all information that is freely available on the World Health Organization website. A lot of it can also be gotten through CDC. There have been a couple of new cases discovered in the Middle East. 4 new member states of the World Health Organization have found cases. They have decided to send a joint mission to Italy because that's where another center seems to be popping up with some. There was apparently a lot of travel between China and Italy. They have so far confirmed that globally there have been about 80,000 cases of this new coronavirus, COVID-19. 500 new, or excuse, that was in China. They've had 500 new cases, 390 new outside of China. And again, I don't necessarily want to blow a lot of this off, but because this is a serious condition, if you get it, but you are far more likely to get something like the flu, which I hope you've all gotten your flu shots right now, but if you haven't, beg, borrow, steal from your provider, see if you can get one, because that is a far more threatening situation. It may not be as sexy, it may not have the supposed mortality rates and things like that, but you're far more likely to be exposed to that than to this coronavirus thing. Much like the COPD Foundation, WHO is saying limit human-to-human transmission, including reducing secondary infections between close contacts. So if you knew somebody who had gone to Wuhan, stay away from them for a couple of weeks. As well as healthcare workers, we want to prevent transmission amplification events, prevent further international spread. And I know there's a lot of distrust of China right now, and if I can soapbox for a minute, probably warrantedly so, but they have done a pretty good job of shutting down a lot of travel and isolating stuff to kind of reduce a lot of the potential risk. Also want to address crucial unknowns regarding severity, extent of transmission and infection, and that's really where a lot of this is coming in right now. There's a lot of stuff that we literally do not know about this coronavirus, and unfortunately, because there are a lot of people who don't trust China, there are a lot of people who don't trust the government, there are a lot of people who don't trust a lot of our institutions or a lot of this stuff, it's real easy to make the leap between not trusting and they must be hiding something. And I would stake my license, my clinical reputation on it that right now, particularly WHO, there's nothing to be hidden. There's not stuff. If they don't know something, they don't know something, but that's different than actively trying to hide it. Also, communicate critical risk and event information to all communities and counter misinformation. So, for example, you saw some articles today about how on Amazon, some of the non-Amazon sellers at the Amazon Marketplace have been basically price gouging respirator masks and stuff like that. That's not going to work. Those are not going to work for you. You're better off just washing your hands and avoiding people and covering your mouth with all that kind of stuff. An N95 mask is unlikely to protect you in this setting unless you are an actual healthcare provider working in a coronavirus ward. It's not going to help. But much like the snake oil that we're going to be talking about, there are people who are taking advantage of this fear, uncertainty, and doubt to make a quick buck, which is kind of garbage in my opinion. So the bottom line for their recommendations: if you are not in an area where COVID-19 is spreading, or if you have not traveled from one of those areas, you have not been in close contact with someone who has or is feeling unwell, your chances of getting it are currently low. However, it is understandable you may feel stressed and anxious about the situation, so it's a good idea to get the facts to help you accurately determine your risks so you can take reasonable precautions. So again, if you haven't gone to China, if you are living with somebody who's gone to China, working with somebody, so on and so forth. Another thing to point out, for most people, COVID-19 causes only mild illness. It can make some people very ill. Older people, as those with pre-existing medical conditions such as high blood pressure, heart problems, diabetes, do appear to be more vulnerable. So we look at some of the other data that's come out, and I promise the dry stuff is almost over. 80% of the cases have been they really have been very similar to a common cold. 20% have been more severe, and 14% have been pretty severe, 5% have been considered critical, where they've had respiratory failure, septic shock, multiple organ system stuff. That's where you're going into the ICU. So again, only 5% out of the 80,000 have even had this. So, and this is just use your heads, be cautious, don't take it too lightly, but also don't lose your head about it. That's kind of the bottom line with this stuff. Don't give in to the fear, don't give in to the panic. As I always say when signing off, take care of yourselves and take care of each other. Make sure that you're chill on stuff. So we'll take a moment here before we get into the meat and potatoes of today, just to say hello to Gabby Davis and Octavia. Octavia, I have not forgotten. Octavia has been a longtime group member also, and just had a comment in the group, couple of comments in the last over the last day or so. Haven't forgotten about you. Just I wanted to do a little bit of research so I can give you an informed answer to some of those questions. Julie, Mary Lou checking in. Appreciate everybody stopping by this afternoon. Let's see what else we got going on. Anything else? Okay, I think we're good. So, on the note of talking about so I almost forgot this part. Again, this is the same thing I said last week. Wash your hands, don't touch your face. If you see somebody who's sick, keep away from them. If you are sick yourself, stay at home. Keep things clean, keep surfaces clean, all that kind of stuff. It's general information. So, we had this whole idea of snake oil. And the original, you may end up noticing a few common threads in a lot of the discussions with coronavirus and with some of the stuff we're going to talk about today. Snake oil actually kind of started, believe it or not, with relatively good intentions. Back when they were building the Transcontinental Railroad, there were a lot of people who came over from Asia, particularly China, who were working on the railroad all the livelong day. And a traditional Chinese medicine remedy is actually the body oil, the fat and blubber from an animal called the Chinese water snake. You would rub it on your skin, particularly joints and things like that, and it really had some pain-killing qualities. That was actually documented. And so these folks came over from China and they were working with Americans who were also working on the railroad all the livelong day. And I've never done railroad work, but I understand it's fairly demanding. And I would imagine that pounding in spikes all day and toting the ties around and all that other stuff, you get kind of sore. So in the spirit of friendship, these Chinese workers shared their snake oil liniment with their American friends. And it worked. Now, of course, we don't have the Chinese water snake in America. So these other workers started looking for other snakes to try to figure out, well, can we have something that has the same effect? And something about the particular chemicals, and I didn't dive too deeply into it, but there's something about particular chemicals and all that stuff in this particular snake that do have these anesthetic powers. Not so much with what was most commonly used to try to do this, which was a rattlesnake. And so there was this guy, he's not on the list here, his name is escaping me right now, can probably search it up real quick and find that out. He was kind of the king of rattlesnakes, and he started making this ointment, this snake oil therapy. And let's see, I actually found another recipe for one. Where was it? Here we go. The viper oil, where you were supposed to take 2 pounds of live snakes. This is from the 1700s, so this is actually a little bit before modern-ish snake oil. 2 pounds of live snakes, 2 pounds 3 ounces of sesame oil. Cook them all together, cover it in a glazed pot until the meat pulls away from the bones. Strain and store. And this oil would then clean the skin, remove pimples, impetigo, and other defects. So not so much with the pain-killing qualities. Excuse me, and I do not have any 18th century references to verify any peer-reviewed studies to tell us whether that worked for acne and so on. But again, basically this whole idea was the snake oil. Now it didn't work with the rattlesnakes, so what this king of rattlesnakes did was he actually took mineral oil, plain old mineral oil, mixed it all together, and then was selling it as this miracle cure. Well, this was about the time that the Food and Drug Administration started coming on the scene, and they actually had requirements. And so he was importing this from somewhere or other, and it got stopped at the border, and they took it out, and they captured it, and they actually looked at the ingredients. They did a chemical analysis, and they found that it was mostly mineral oil, and so they fined him about what apparently would be about $400 in modern money for violating the Food and Drug Act. But In the meantime, I suspect he sold far more than $400 of this ointment. And that's kind of the common theme of a lot of these folks, is they are basically there to make a quick buck off of something that seems legit. And now, again, some irony here. I want to introduce you to a friend of mine. We'll do this there. This is a gentleman named Greg. And actually, you are watching this show right now because of Greg. Back in... It's been about 5 years now. This was about 2014, 2015. I had done some research into COPD education, and my dad was a teacher, so I was very interested in educational techniques and all that stuff. And this was about the time I started getting my interest piqued in COPD. I had been doing a lot of intensive care and inpatient stuff before then, and now I was looking into some other avenues. And I saw that we were doing a very poor job of teaching people how to manage their stuff. We weren't doing it in good settings with good methods and all that. So I learned a little bit more about teaching techniques and all that stuff, and I found that, adults learn different than kids, which probably surprises exactly zero of you. And adults like to learn, some adults like to learn with pictures, some adults like to learn with videos and discussions, some like to read a book, or listen, or watch a lecture, or make a song, or listen to a song, where we have rhyming songs, where we listen to mnemonics, all that kind of thing. Everybody learns in different ways. And so long story short, I discovered that Facebook was a really good platform for that. You could make a graph, you could make a chart, a diagram, a video, audio. You could do all these things. You could have somebody ask a question, and they didn't have to make an appointment. It could be what we call asynchronous. You could ask a question now, and then three hours later, you can get it answered. Or you could go back to it. It was a good reference. You could search through the group. So I went onto Facebook, and I was not new to Facebook at the time, but I hadn't, I used it like most people do at the time for funny cat pictures and all that kind of thing. And I was looking at some of the groups that were out there. I wasn't really in a lot of groups or anything like that, so I didn't know a lot about them. And I found a couple that were COPD oriented, and I found one in particular that seemed like a pretty good group. And a lot of people, a lot of good discussions, and so I went in there and I introduced myself. I'm a respiratory therapist. I know a bit about COPD. I'm not bought and sold for by anybody. I don't work for anybody in the industry at the time. I will disclose I do take some speaking fees from time to time here, but as one of my other colleagues tells me, aim for being so conflicted you're not conflicted anymore. So that's why I'm always very careful. I try not to endorse one therapy over another. I try to be as objective as possible, and if you have any complaints or concerns, I'm happy to address them. But in any event, at that point, I wasn't involved with anything. And so I started answering people's questions, and it was nice. I was able to be helpful. I was making a difference. The administrator of the group, Greg, was not there. He was not present. And then all of a sudden, he came back. And it turned he started getting real ticked off that a clinician, an objective clinician, was in the group, because it turns out Greg had started the group because he had written a book about how he had cured his mother's emphysema. He had reversed it with this course of certain foods and a lot of supplements, and he had done 6,500 hours of research on COPD, and he knew the secret. He knew the things that people weren't telling us. And this is actually a review of his book. You can go on Amazon and find him. These are not my words, so this is, again, I would expect nobody to take what I say 100% at face value without trying to verify it, just like I'm not asking anybody else to. So he claimed to spend 6,500 hours on research and discovered the means to wipe out the unknown pathogen that causes COPD. Now again, even 5 years ago, we knew that the vast majority of COPD is caused by tobacco smoke, with about 20 to 25% caused by environmental factors, environmental pollution, secondhand smoke, wood smoke, alpha-1 antitrypsin deficiency, genetic stuff. But it was his 65,000 hours or 6,500 hours of research pointed him that it was a fungus, basically systemic candidiasis. So this person that bought the book states that it became very obvious to me very quickly that this core premise of his reverse COPD treatment and around the book was written, but he doesn't tell you this. He doesn't tell you it was a systemic fungus. And in fact, the questions in the author's impressive reverse COPD self-test were basically self-copied from a self-test for Candida overgrowth. Now, Candida is like athlete's foot. Can also be in the body, you know, that bacteria. Also said he treated his mom with nystatin and diflucan, two well-known antifungal drugs used to create Candida overgrowth. So there's no real unknown pathogen. This is all over the internet. It's very difficult to know what was going on. He was never able to show any kind of lung function results. And unfortunately, it turns out that within, according to this person, within 6 to 9 months, I believe, his mom actually passed away instead of having his fungus reversed. And there's a lot of other family drama. He was apparently a squatter in the house, and there's a lot of other stuff going on. And I was caught by this because I hadn't, again, he kind of disappeared for a while. Again, his stuff is still on Facebook and that sort of thing. But not terribly long ago, there was a Twitter account that I follow that automatically retweets stuff with the hashtag COPD. And he went through about 2 days, and he must have paid for a program or a bot, or as they call it, to retweet a lot of his stuff. And so back to the group. What his whole point to the group was I have the secret that the clinicians aren't telling you. Your doctor's not telling you. Your respiratory therapist isn't telling you. Big pharma's not telling you. The big hospital groups aren't telling you. I have the secret, and I will give it to you if you subscribe to my monthly box of supplements for roughly $218 a month. Now you'll know the secret. You'll have support groups, and you'll have all this other stuff, and you'll have these supplements. So, the next logical question is, do these supplements actually do anything? And that is an interesting question, because fortunately we're able to actually kind of take a look at that. But because he is good enough to, while he doesn't give us all the information, he does give us a list of the various supplements that you get in his box of goodies. So he starts with the enzyme, coenzyme Q10. Now, is coenzyme Q10 a bad thing? Is coenzyme Q10 snake oil? I wouldn't necessarily say that. I believe that actually I take enzyme Q10 is part in one of my vitamin supplements. It's perfectly fine. It's not bad. It's not evil. Does it reverse COPD? Well, there's really no evidence for that. It's an antioxidant molecule. It will bring down, theoretically, some inflammation. The next thing on the list was this thing called beta-glucan, which I found was an anti-infective agent that actually can be given intravenously at times post-cancer surgery, because it does seem to help with infections. It has not been demonstrated to do anything outside of that. There's no evidence to support it. It doesn't really hurt you, but does it do anything? Not really. What comes in the box is apparently 7 times more effective than their closest competitor. Is that a good thing? Is it 7? Last I checked, 7 times 1 is 7, and 7 times 0 is 0. So if it has 0 effect, 7 times as effective of that is close to 0. Oh, I was curious. I thought maybe I had a spam comment. Oh, well, I kind of do. Let's see, but it's not popping up anymore. So that's probably just as well. On YouTube, I thought maybe I might have had one of those. You'll notice from time to time, I try and catch them pretty quickly. I get a lot of random people who are like, well, I was diagnosed 10 years ago, and then I found a miracle doctor so-and-so who cured this and cured that. Again, we've got Lots of snake oil going. Judy says no video. No sound. What happened? Coming through for anybody? Because as far as I can tell, it's... Well, I guess I can... An easy way to check that too. One moment, folks. Maybe I've said too much, and they are coming to get me now. Let's see what we got here. Maybe I've underestimated the power of snake oil. Your face to help capture it. Check that too. One moment, folks. Maybe I said. Oh, there's a weird echo going on. That's for sure. Ah.
That should take care of the echo. Sorry about that, folks. Yeah, let me know when there's glitches and stuff, though. All right, well, I fixed the echo. It turned out it was actually drawing from both the camera microphone and my actual better microphone. So apologies for the echo. Wouldn't be BreatheTV if something didn't go wrong, right? In any event, getting back to the point here, part of the issue is, I'm trying to remember what I was going on about. We had just talked about beta-glucan. Did it work? Next thing on the list was probiotic, which again I took for a while after I had some stomach surgery a few years back. Had to take that for a while to kind of repopulate. There's a lot of studies going on right now about what's good bacteria, what's bad bacteria. But again, okay, that's fine. Is it worth $200? I guess that's your call. I don't think so. Now, omega-3 fatty acids. This is a pill that has specifically omega-3 fatty acids. Now, we talked about this a couple weeks ago because we found that there was a difference between omega-3s and omega-6s. But again, this is stuff you can just get from particular foods. You can get it from a supplement. And much like the vitamin D that we talk about a lot, there's not a lot of evidence that tells us the more the better. We know that if you don't have enough of some of this stuff, it's bad. If you don't have enough vitamin D, that's bad. If you don't have enough omega-3s, that can be bad. If you don't have enough coenzyme Q10, that can be bad. But do you need more than normal, more than usual? Not according to the data. Data is always evolving, so I'm not going to say absolutely not, but we don't have any evidence of that. And why I'm going through this whole list will become apparent in a few minutes. Trust me. Stick with me, and there will be a payoff at the end. Also, next on the list is N-acetylcysteine, or NAC, which again we've talked about a couple of different times. Another potential antioxidant. When taken in pill form, please, for the love of whatever you believe in, do not take the inhaled version, which is usually called Mucomist. That is terrible. All it does is make you smell like rotten eggs, and it has absolutely no effect. Although I guess there was a doctor that took some issue to that on Twitter the other day. Apparently, if you have some kind of airway stenosis, it can help a little. Okay. For COPD, it does not work. The pill form seems to work, seems to demonstrate some improvement under certain circumstances with the right dose and all that kind of stuff. Then it also has a particular brand of vitamin and mineral tablets that absorb better than any other vitamin we have tested and contain enzymes for added internal energy. Woohoo! Okay. And finally, advanced oil leaf extract with the highest absorbing oleuropein on the market, and including celery seed extract for added absorption. Sure, why not? So you could what's interesting? What's the point here? And is that my next? Well, it's part of the next topic here. All of this stuff. First of all, it sounds plausible. Like you go on the website and it's like, well, it's got the most absorbing and the fastest acting and the most this and this is the best, and sounds great. And there's just enough there. We know, again, Q10, that can work. the beta, whatever it was, that can work. NAC, N-acetylcysteine, that can work. There's just enough there to kind of get you into that cusp of belief. And then he'll put the whole package together for you. It'll be nice and convenient. And I got a deal for you. I'm going to save you $5 or $10, and you get this whole package shipped right to your door for $200. Isn't that great? And it's going to reverse everything for you. It's going to be fantastic. That's the power of snake oil. There's no evidence to this stuff. Together, there's very little of it separately. This is not going to be a real compelling thing. But if you put it together and you sell it right, you're going to be able to do that. And the other issue that comes into play here is there is no worse feeling than not being able to breathe. I get that. I don't do it chronically, so I don't know what it's like all the time, but I have gotten short of breath. I've gotten sick where I can't breathe. I've aspirated stuff and I can't get air in. You have water go down the wrong pipe or whatever. I've had spit go down the wrong pipe, and every time that happens to me, I think to myself, how ironic is this, that the respiratory therapist is going to die because he chokes on his own spit. Can't even manage his own airway. What kind of respiratory therapist is he? It preys on the desire to feel better, going all the way back to the railroad workers who wanted to be less sore and used actual snake oil and felt better from the right kind of snake. And then they weren't able to translate that any better. But people said, oh, you want to feel better? Well, maybe we can't get that snake oil, but this one's going to be just as good. And then when you couple that with the idea of the whole placebo effect, where you can convince mind over matter, you can convince yourself if you believe strongly enough, there are some people who may feel better. A lot of what we deal with in COPD is very subjective. We can measure emphysema type damage. We can do a chest x-ray, more like a chest CT. We can do lung volume testing, body plasmography or gas dilution volume testing, pulmonary function testing. We can tell you how much air is trapped in your lungs. We can look and see, yes, those airways look inflamed. We can see, as far as, there was a question in the group today that I also need to get to about bronchiectasis, which we talked about a couple weeks ago. We can see if that's there. We can see if there's been any progression. But as far as being out of breath, that's for you to tell me. That's very subjective. That's just like I tell people all the time. It's like the pain scale. One person's 5 is another person's 10. If I ask you how out of breath you are on a scale of 0 to 5, which is one of the questions we ask, if you were to climb up a staircase, on a scale of 0 to 5, how out of breath would you be? There might be people who have the exact same degree of airflow obstruction on spirometry, the exact same amount of emphysema, the exact same amount of mucus production, and have wildly different sensations of shortness of breath. But if you tell yourself enough times that, yeah, I do feel better, yeah, I do feel better, yeah, I do feel better, you may well start to feel better. And when that happens in the setting of the snake oil stuff, then you all of a sudden, now you have a testimonial. Now you have somebody agreeing with you that, yeah, you feel better. And that's where some of these other groups come in too. This is this idea of stem cell therapy for lung improvement. There have been a couple of groups going on about this, and this is a potential area for research. This has that kernel of truth to it. But there's no data yet, and the methods they use are not fantastic. Now, again, you look at their website. I'm going to come over here. You look at this website. I'm not going to tell you which one. If you get too super curious, you can go find it, but I don't want to really drive their traffic all that much. It looks fantastic. There's animations, and they've got all these numbers, and 96% patient satisfaction. Well, sure. First of all, the thing is like $10,000 or $5,000. It's ungodly expensive. And are you going to admit on a survey that, yeah, I got duped? It's hard for people to admit when we got something wrong, or when we got the wool pulled over our eyes. It is for me, at least. It looks great. It looks fantastic. And they've got people who feel better because not only are they getting the therapy, but they're also maybe exercising a little bit more. Maybe they're getting out and about a little bit because, well, if I'm going to feel better, I better start doing this other stuff. Maybe they're a little more adherent to their medications and they're getting a little bit more bronchodilation, or they're on that steroid and that inflammation's going down. it seems like it's working, and now you have that placebo effect, and now you have a testimonial, and then somebody else comes to the website and they say, well, this looks good to me, and Joe Lung says that worked for him, so what the heck, let's give it a try. There's that kernel of truth, and then they build on that with a good sales pitch. I've gotten suckered in by sales pitches before. I get it. I know what it is. The biggest thing to point out is one of the biggest pitches, parts of the pitch, these are the things to look for, is that whatever they're selling you is unusually effective. We will cure, we will reverse, we will give you this back. And again, this isn't just for lung stuff either. This is for anything. They claim it's unusually effective. They claim it's the best kept secret. It's something that the man doesn't want you to know about. Well, big pharma, they just have clients, and they're believe me, there are issues with big pharma, and I'm happy to talk about those too. This is not an excuse for a lot of those practices, but medications have a role, just like exercise has a role. Certain surgeries have a role. Not one of them individually is going to be the answer. They all have a role. What I mean by the best kept secret is when you're getting snake oiled, they'll tell you this is the way. This is the thing to do. This is going to solve your problems. You don't need to worry about those inhalers anymore. You don't need to worry about that nasty powder. You don't need to worry about any of that stuff. This is what you need to do. And I'm the one that can give it to you. If I ever do that, if you ever feel like you're getting that pitch from me, please tell me, because that is terrible and I don't want to be that guy. The last thing is that, again, there's just enough truth. And this is that payoff that I was telling you about. Remember, we were talking about there's just enough that NAC, the N-acetylcysteine, might work. That's a reasonable thing. And if you go out and you look, even on PubMed, the peer-reviewed database, you'll see, yeah, it seems to have some anti-inflammatory effect. You'll find the CoQ10. You'll find all these things there. There's just enough of that kernel of truth to say, okay, well, maybe I am going to be part of the club. Maybe there is something cool here, and I can get in on it first. And then they've got your hooks into you. And that's where things really go awry. Now, we've talked a lot about intentional snake oiling. But there was a situation that popped up in our Facebook group earlier this year. And I generally try to give people the benefit of the doubt. I don't think this person really had malicious intent. There is an aspect of it that is potential, because this was somebody who had, I believe it was personal training services and all that kind of stuff that could be sold. Seemed like maybe it was headed toward a slow pitch. Then we had some issues because this person started making absolute statements without any support. You can never, I believe the particular one was, you can never ever drink milk because milk makes you produce more mucus. Sometimes that's true. Some people that happens. Many people it does not. And even the people in which it happens, does it have a clinically significant effect? We don't know. Not always. So it's very difficult to use absolute statements, but this person was refusing to back down. And again, I encourage everybody to be involved in their own care and all that sort of thing, to do your own research and all that stuff. But you also have to be mindful of this thing called the Dunningkruger Phenomenon. And this is a really common thing these days because we have access to vast amounts of information and data and interpretations and that sort of thing, arguably more than at any other point in human history. And so it's really easy to learn a decent amount about any given subject. But as you can see from the graph, you start at that low confidence and low knowledge thing. We talk about COPD. And when I started respiratory school, I had never even heard of COPD. This was before any of the commercials. This was before any of that stuff. So I had no knowledge. So obviously I had no confidence. I was at the Then you start to learn a little bit about it. And it's like, oh, okay, I got it. It's you got the throwback to my clinician friends. You got your pink puffers and your blue bloaters. You got your chronic bronchitis. You got your emphysema. You give them some inhalers and maybe you do that what's it, pulmonary rehab, that send them to the exercise thing, and And that's it. Now I know all there is to know about COPD. And arguably, that's where I was when I started doing some of that research. And then the more I looked into where are we at with teaching and where are we with these things, and I got more involved, I started kind of second guessing myself. It's like, okay, I've learned a little bit more now. There's a lot more that I need to learn. There's a lot more to this than I thought, as the graph says. And then it can be kind of overwhelming. It's like, there's all this stuff, and then you start to realize what you don't know, and there's so much that you don't know, because it's really hard to know all that is knowable. I mean, it can be overwhelming, but then you start to know enough to be practical, and you kind of go from the knowing enough to be dangerous to knowing enough to be practical. It's starting to make kind of some sense here. Okay, I can get this, and I can start having an impact. And then you get confident enough that you can maybe start teaching it a little bit more, and you can try to encourage people like, yeah, it's complicated. There's a lot. You may know a lot right now, but there's so much more to know. And then that's when you kind of get, there's longer curves that talk about sustainability and all that kind of thing. And unfortunately, it's really easy to get stuck at that peak of knowing everything, because when you think you know everything, then you stop seeking to learn. When you don't think there's anything else there, your motivation kind of drops a little bit. And because many of you may know I like Star Trek references, I came across this. I think about this a lot. This was from an episode of Star Trek The Next Generation where Data, the android, has created an offspring android. And they're talking about humor, something he was never able to laugh, never even really able to joke. But something that his android daughter Lal said made somebody laugh. And so she said, so without understanding humor, I have somehow mastered it. And that's where a lot of people get stuck when we're talking about a lot of different topics, but particularly in healthcare. This is where we get kind of the whole anti-vax movement. This is where we get the snake oil people. This is where we get a lot of these people who are preying on people who don't know a lot. Don't know as much as they would like to, and it's really easy with a polished sales pitch to get suckered in by a lot of this stuff, especially when you have motivation that you want to breathe better. When you're really passionate about wanting to breathe better, you get stuck with it. So I know today got a little soapboxy, but I'm very passionate about this. I hate seeing people getting taken advantage of. And it's really frustrating that this kind of thing still goes on Amazon and on YouTube and a lot of these different places. So please, by all means, do not take my word for it. I am not here to tell you that I know that I am the be all end all. I don't know everything. I don't know a lot of stuff. There are a lot of people who are much smarter than I am who probably disagree with a lot of this stuff, and they could very well be right. Do not just take my word for stuff. Do not just take Greg's word for stuff. Do not take any one person's word for stuff. Make your own decisions. Make sure that you're getting information from respectable sources. And we can do a whole other talk about what's respectable, but make sure they're not trying to sell you something. Make sure they're not trying to push you away from something. Make sure that they are relatively objective. And then make your own decisions based on as much objective data as you possibly can. How to recognize when you're getting snake oiled. If it sounds too good to be true, it is. Sadly, there's not a lot of cures for a lot of the stuff we see all the time, COPD among them. If somebody tells you that they have a cure, they're selling you something. If it's too good to be true, it is. Trust but verify. Again, I try to give people the benefit of the doubt. I try to, when somebody makes a claim, it's like, okay, well, let's look into that. What kind of data do you have to support it? What kind of trial did you do? What do you have here? What's this? Is there other backup information? Be somewhat trusting, but don't just jump into anything either. And then last but not least, remember the Dunningkruger folks. Be careful even of good intentions. Like I said, not everybody is selling you snake oil on purpose. Doesn't make it any better. Honestly, people should be able to recognize, people on our side, on the clinician side, should be able to recognize when we don't have the appropriate information. That's why, again, we talked earlier, there are a couple of questions in the group that I didn't want to answer right away. First off, I like to let other people who are walking the path get first crack at it. But I also don't want to just spout off on something that I don't really know about. I want to get my information together. I want to do my verification. and give the best possible answer. So unfortunately, not everybody does that consistently. I'm sure I've broken down a time or two. Well, I know I have. I've had to eat crow a couple times, but that's also human nature. So with that, appreciate everybody coming by. We do have some time for questions and answers. I'm going to loop back around. I know I've got one. I know I've got one. We have one question about metformin. So I'm going to jump back here, just kind of take a look around for just a second, make sure not missing any other comments here. But so let's see what we've got with metformin. So let's see, about a year ago, there was an article in the American Journal of Managed Care that tells us that metformin can be effective of the adverse effects of diabetes on patients with COPD, which is probably a good thing because that's what metformin is supposed to do for everybody. So they looked at, this was a 6-year study that found over 4,000 people with COPD from the National Taiwan University Hospital, 13% of whom also had diabetes. Those folks were also more likely to have high blood pressure, cerebrovascular disease, heart failure, coronary artery disease, kidney disease, some kind of malignancy. The people with both COPD and diabetes were 1.5 times more likely to pass away in 2 years. Okay, so when you were on metformin, you were less likely to die prematurely. So again, that's good. That's kind of an odd study. It's kind of what metformin's supposed to do for everybody, like I said. Let's see if there's anything else going on. So here's a clinical study. So if what I also send out there real quick is first off a hello to Susan and to James from out west, at least relative to me. Jenny, if you happen to still be watching, if there was something specific that you knew about metformin, let me know, because I'm not seeing a lot of. Let me pull up the PubMed real quick, that peer-reviewed journal. I'm going to do a search for metformin and COPD. If I can get cooperation here, metformin, COPD, and let's see what the most recent journal article was. Okay, so there is a systemic review for the role of metformin in COPD just last year again. I love systemic reviews. It's safe and effective in patients with COPD with simultaneous type 2 diabetes, based on 6 articles, which may improve benefits. So if you've got COPD and diabetes, take your metformin, I guess. Was kind of okay. So here is potentially an interesting one. That's the last one that I see for. Oh, well, we're gonna do one other one there from 2018. There was one that in respirology last year, 5,000 participants followed over 6 years in the U.S. If you had, okay, so this is again basically, well, I guess kind of in general, probably associated with. Okay, so the idea was metformin, common anti-diabetic drug with anti-inflammatory and antioxidant properties, may improve respiratory outcomes. So in these 6,000 people, they did in fact find lower chronic lower respiratory disease mortality for, don't see a lot specifically. I don't know if I can get the full text article to get a percentage for you, but yeah, again, this is pretty good review. So I can't see exactly what percentage decrease, but I would imagine it was probably similar to that other study where we did see lower percentage of that. In 2018, there was a study that actually looked at an inhalable form of metformin. Preclinical, so this is probably still under investigation. This looks to be more like just a potential kind of article. So yeah, basically just saying short half-life, doesn't stay around too long. Beneficial effects and pathological conditions found in pulmonary disease. So interestingly enough, it could be that inhaled metformin is a potential new therapy, which is something I had never heard of before. Inhaled metformin. Let's see if there's anything else there real quick, and then we'll see if there's any other questions. While I'm doing this, if anybody wants to throw in a couple more questions there, that would be great. So we've got two more that might be related. Metformin, it's more blood clots, so that's not going to be helpful. Didn't really, so in an exacerbation state, didn't really have much effect on blood glucose even for that, or C-reactive protein, which is an inflammatory marker or clinical outcome. So it may be helpful in the management. The ongoing control phase did not seem to offer much benefit in the hospital for exacerbations. So again, if you have diabetes, if you have COPD, you should probably take some metformin if you can tolerate it and there's not an adverse effect. So there you go. Hopefully that was of some benefit. What else we got here? We got any other questions coming in? Can metformin replace prednisone? I would say that there's not data for that right now. I'm kind of intrigued by the mention of that article with the inhaled metformin. That also seemed to indicate that when you take metformin in its normal form, orally, by a pill, most of it still stays in the gut. It does have some other anti-inflammatory stuff, but most of it seems to stay in the intestine area. Metformin versus prednisone. Metformin prevents diabetic side effects during prednisone treatment, so that's good. But I don't know that as of now, I don't think we have data that tells us that you can replace it. I would be intrigued if you ask me that question again in 5 years to see where we're at with some of this inhaled stuff. I think that might be very interesting. But we're not there yet, unfortunately, so it would not be a replacement. Again, if you're on prednisone, and if you are at the least bit prone to any kind of diabetic stuff, as many people are, I would encourage getting some of that to go along with the prednisone. But I would also make sure that I would also encourage you, if you have issues with your blood sugar, make sure you're talking to an endocrinologist too. That's more my wife's realm of expertise, working in obesity and bariatrics, metabolic stuff. But seems like it might have some potential there. So let's see, got any other questions going on here? Let's see. Wow, we've got a lot in the group. Why can't I see? Oh, maybe those are the hello to Esther and Kathy checking in. Let's see. See real quick here if, much like our sound issues, sometimes we have some trouble with getting all the comments in, but I think we've covered all of our bases here. So again, I appreciate everybody coming in today. I'm going to check one last thing. And again, please feel free to spread the word here. We're still trying to, for some context, my old friend Greg there, he's got a lot more Twitter followers than I do, so if I can amplify my message over that message, that would be fantastic. Please feel free to share these videos. And the whole idea of COPD Navigator, you can see email, we've got Twitter. If you're watching us on Facebook, you've already found the Facebook. We do have a group by the same name that you can click on with the link on the COPD Navigator Facebook page. Make sure you're following the COPD Navigator Facebook page to get notifications of these videos, which we do about every 2 weeks. Wednesday afternoons at 4:30 Eastern Time. In 2 weeks, we're going to be talking about inhaler technique. Once again, this is something that pops up a lot, but it is critically important. We know that we've had a lot of trouble for the last 40 years with people with inhaler technique. We know the rates of critical errors haven't changed very much. The rates of other errors haven't changed very much. And it's my supposition that that is why we haven't seen a lot of impact on COPD impact. You know, the mortality rates, the disability rates, all that kind of thing. We're giving people these tools and then we're wondering, well, why isn't anything changes? And we're getting frustrated. And it's like, well, when you look at the technique, we have a lot of accidental non-adherence, what I call. We have a lot of people who think they're using their tools and are getting frustrated because they're not getting any better because we as clinicians haven't ever taken the time to teach them how to use the tools. So we're going to be talking about that a lot in 2 weeks. We're going to have a lot of demos. We're going to make sure that you are using your inhalers properly and have the tools you need to talk to your provider or potentially your insurance company, which is a whole other can of worms, about getting onto the right inhaler, the right device, and the right medication. Also, I believe we're going to be ready for it next week. We're going to start doing I'm doing a podcast. I'm breaking into that world. You can already find the audio copy of this program on wherever you look for podcasts, Spotify, Google Podcasts, Apple Podcasts, a website called Anchors where it's hosted. You can look for that. I'm going to be doing one that's a little bit more general topics, starting with the idea of prior authorization and why do we do that. I'm going to try to bring some clarity to a lot of more general healthcare topics that we don't often talk about, how healthcare works on the administrative side, costs and things like that. It's very important as we get into what promises to be controversial discussions about the idea of Medicare for all, or how do we adapt our current system to give us some better outcomes and maybe not spend so much money. But in order to do that, we've got to understand how we got here and why things are the way that they are. So look for that. You'll be able to find it by searching for my name. It is called the Potato Cast because it's named after my cat. I had a cute picture of my cat when I first got my microphone set up, talking into the microphone, and a friend of mine and then my daughter reinforced that this should absolutely be called the Potato Cast Podcast. So it's billing it as the world's finest healthcare podcast named after a cat. So look for that in a couple of weeks. Thank you, Joe. Expertise is always a strong word for me, but I appreciate the vote of confidence. Look forward to seeing more of you around the group. Again, search for us on COPD Navigator on Facebook and on YouTube. Come visit us. Not much going on the website yet. That's an ever-developing project with everything else going on. Hope that everybody has a great rest of your Wednesday. James doing inhaler teaching this month. Family practice clinic, docs, RNs, MAs. That is fantastic. That is the best possible place to be doing this stuff. As Dr. Thomas Shaw from the COPD Foundation says, COPD has to live in primary care. So let's get our primary care folks. That's where I work. I'm fortunate enough to work. Let's get our primary care folks learned up on this kind of stuff. Again, see everybody around the group. Hope everybody's having a great Wednesday. If you are in the path of this winter storm, hope you're staying warm and comfortable. Make sure you're covering your face out there. Make sure that your air filters are cleaned, all that good stuff. Take care of yourselves, take care of each other, and I'll see you back in 2 weeks.